Imagine this. You're 74 years old. You feel good. You're sleeping well. Your energy is decent. You're still doing the things you enjoy. You go in for your annual physical, routine, nothing special. Your doctor glances at your chart and says, let's just run a few tests, to be safe. 6 weeks later, you're sitting in a specialist's office. Not because anything was actually wrong with you, but because that just to be safe test found something. And that something set off a chain of events your body wasn't necessarily built to handle at 74. This exact story plays out more often than most people realize. And it deserves a real conversation, not a scary one, but an honest, evidence-based one. My name is Dr. Kaur, and this channel exists for one reason, to help adults over 60 understand what the research actually says about their healthcare, in plain English, without jargon, and without an agenda. Here's something most doctors don't have time to explain in a 15-minute appointment. After age 70, some of the most common routine medical tests can, for certain people, cause more harm than good. Not because medicine is broken, but because the math of risk versus benefit genuinely shifts with age. And often, nobody is walking through that math with you in the room. Today, I'm going to walk you through 5 specific screening tests worth a second look after 70. I'll explain why the calculation changes, I'll walk through realistic scenarios, and at the end, I'll give you a simple framework of questions that can completely change your next doctor's visit, for the better. Stay with me through all 5 because number 3 surprises a lot of people the first time they hear it, and number 5 is something most people have never even had explained to them. Alright, let's get into it. Before we talk about the 5 tests, I need to give you one framework because without it, nothing else will fully click. I call it the longevity lens. At age 50, screening medicine works beautifully. You find a problem early, you treat it, and you potentially buy yourself 2 or 3 more decades of healthy life. The investment is almost always worth it. The math is clean and simple. But somewhere after 70, 3 things change. Quietly. Without anyone announcing it. First, many conditions found through routine screening in older adults will never actually cause harm. They grow slowly. They stay silent. Statistically, a lot of people will live out their natural lifespan without that condition ever becoming a problem. But medicine, as a system, doesn't have a well-developed let's just watch it button. It has a let's treat it button, and that button tends to get pressed by default, almost automatically, once something shows up on a report. Second, your body's tolerance for intervention drops with age. A surgery that a 55-year-old bounces back from in 2 weeks can mean months of recovery for someone in their late 70s or 80s. Sometimes it means a loss of independence that never fully reverses. This isn't pessimism. It's simply physiology. Healing capacity, immune resilience, and anesthesia tolerance all shift with age. Third, and this is the one people find most surprising, the cascade effect. One small, borderline finding on a routine test triggers a follow-up scan. That scan suggests a biopsy. The biopsy leads to a procedure. The procedure carries its own risk of complication. And suddenly, someone who walked into a doctor's office feeling completely healthy is now navigating a months-long medical journey, one that started with a test that, in hindsight, may not have needed to happen at all. I want to be very clear about something before we go further. None of this means tests are bad, or that doctors are doing something wrong. It means that the right questions change with age, and very few of us are ever taught what those questions are. That's what this video is for. Keep the longevity lens in the back of your mind as we go through each of the 5 tests. Ready? Let's start with number 1. Let's walk through a realistic, hypothetical scenario. We'll call her Margaret, 77 years old, a retired school teacher. She'd had 2 colonoscopies in her 50s and 60s, both completely clean, no polyps, no family history of colon cancer, no symptoms of any kind. Her new primary care doctor looked at her chart, saw it had been a while, and recommended another one, mostly out of habit. Margaret went ahead with it. The prep, the liquid you drink the night before to clear the bowel, hit her kidneys hard. She's not alone in this. For older adults, especially those with even mild kidney issues or those on certain blood pressure medications, this prep can cause serious dehydration and electrolyte imbalances. In some documented cases, patients have ended up in the emergency room or even hospitalized for several days before the colonoscopy even happened, dealing with a complication from the preparation itself, not the procedure. Here's what the actual guidelines say. The U.S. Preventive Services Task Force, the government-backed body that sets national screening recommendations, states that for average-risk adults with a clean screening history and no symptoms, routine colonoscopy is generally not recommended after age 75 and is specifically discouraged after age 85, where the risks tend to clearly outweigh the benefits. Why? 2 reasons. First, colonoscopy itself carries a real, if uncommon, risk of bowel perforation, a literal tear in the colon wall. In a younger, healthier adult, this is a serious but generally manageable surgical complication. In a frail 80-year-old, it can mean emergency surgery, a colostomy, and a recovery that fundamentally changes day-to-day life. Second, the colon cancers most likely to show up incidentally in an asymptomatic older adult tend to be the slow-growing kind, the kind that, statistically, might never become life-threatening within that person's remaining years. But, and this is important, none of this applies if there are symptoms. Blood in the stool, unexplained weight loss, a real change in bowel habits, or a strong family history of colorectal cancer completely change the calculation regardless of age. In those situations, screening and follow-up are appropriate and important. A question worth bringing to your next appointment. Given that I have no symptoms and a clean screening history, would a non-invasive option like a FIT test or Cologuard be a reasonable alternative to another colonoscopy this year? That single question often opens up a much more thoughtful conversation than a routine referral slip ever will. This next one deserves real nuance, so let me say this plainly, twice if I have to. I am not telling you to skip cancer screening. Cancer screening has saved an enormous number of lives, and for many people, it will continue to save lives. This is not an anti-screening video. What the research does point to is something called overdiagnosis, and it becomes more relevant after roughly age 75 in average-risk, symptom-free individuals. Here's what overdiagnosis actually means, in plain terms. Modern imaging technology is remarkably sensitive enough to detect cancers that are, biologically speaking, almost dormant, tiny, extremely slow-growing tumors that, left untouched, would likely never cause a symptom and would never shorten that person's life. The person would eventually die with the cancer, not from it. But here's the catch. The moment a radiology report contains the word malignancy, the clinical machinery tends to move forward. Biopsies get scheduled, specialists get involved, treatment decisions get made, often without much discussion of whether this particular cancer, in this particular person, actually poses a meaningful threat. Let's imagine another realistic scenario. A 79-year-old man, still independent, still active, we'll call him Walter. A routine PSA test comes back mildly elevated. A biopsy confirms a low-grade, slow-growing prostate cancer. Radiation is recommended, and Walter goes ahead with it, trusting the process. Within a year, he's dealing with fatigue and urinary complications that meaningfully affect his day-to-day life. For a cancer that, based on its grade and growth rate, may well have never caused him a problem in his remaining years. This kind of outcome is documented widely enough in the medical literature that urologists themselves increasingly discuss active surveillance, monitoring low-grade prostate cancer instead of immediately treating it, as a legitimate, evidence-based option for many older men. On the mammography side, research published in journals including the New England Journal of Medicine has found that a meaningful proportion of cancers detected through mammography in women over 70 were clinically insignificant, meaning treatment provided no measurable survival benefit, only the side effects that come with it. Now, the important caveat. Again, if there's a strong family history, a known genetic marker like BRCA1 or BRCA2, or any actual symptoms, this entire discussion changes. Those situations call for continued, and sometimes more aggressive, screening. A question worth asking your doctor. If something is found, what would the realistic treatment options be for someone my age and health status? And would that treatment meaningfully change my outcome, or just change what I know? That last part of the question, or just change what I know, is often the most clarifying thing you can ask. This one tends to surprise people the most, because on the surface, it sounds completely logical. Your doctor says, "You're 72, let's just make sure your heart's doing okay." And you hop on a treadmill, or you're given a medication that temporarily stresses the heart while it's monitored. It sounds responsible. It sounds harmless. Here's the issue the research raises. In people with no symptoms, cardiac stress tests have a notably high false positive rate, in some populations, reaching close to 40%. That means a meaningful chunk of the time, the test flags something that looks abnormal, even though the heart is actually functioning fine. But medicine, understandably, can't just shrug off an abnormal result. That flag typically leads to the next step, cardiac catheterization, a procedure where a thin tube is threaded through a blood vessel, usually in the wrist or groin, directly into the heart to get a clearer picture. It's a real procedure with real risks, bleeding, vessel damage, arrhythmia, and in rare cases, it can actually trigger the very heart attack or stroke it was meant to help prevent. And here's where it gets genuinely counterintuitive. If the catheterization finds a partial blockage, which is extremely common in adults over 70, many of whom have zero symptoms, a stent is often placed. But here's a key finding from major cardiology research. Several landmark clinical trials, including the widely cited ischemia trial, found that in patients with stable coronary artery disease, meaning no active heart attack, no unstable symptoms, stenting did not reduce heart attacks or extend life compared to medication and lifestyle management alone. Let that sink in for a second. The stent, in this population, did not outperform medication for survival. What it did add was its own procedural risk, plus a long-term commitment to blood thinners, which carry their own bleeding risks, especially in older adults. So walk through that sequence with me, feeling completely fine, routine test, false alarm, catheterization, stent, blood thinners, ongoing monitoring, and, according to the research, statistically no better off than someone who simply managed their risk factors with medication and a daily walk. But again, this is specifically about people without symptoms. Chest pain, unexplained shortness of breath, dizziness during activity, or symptoms that worry you personally change this picture completely. In those cases, testing is appropriate and important, and you shouldn't hesitate. A question worth asking your doctor: since I don't have any symptoms, would focusing on blood pressure, cholesterol, blood sugar, and activity level be a more appropriate starting point than a stress test right now? This one deserves real care, because osteoporosis is genuinely serious, and falls are one of the leading causes of loss of independence in older adults. I want to be very clear that I am not minimizing that risk at all. What's worth looking at closely is the automatic pipeline that sometimes follows a DEXA scan. The scan shows lower than average bone density. A bisphosphonate medication, something like alendronate or risdronate, gets prescribed. The patient takes it for years, often without much further conversation. Here's what sometimes gets left out of that conversation. Long-term bisphosphonate use has been associated with two rare but serious risks. The first is atypical femoral fractures, unusual, sometimes spontaneous stress fractures in the thigh bone, the very bone the medication is meant to protect. The second is osteonecrosis of the jaw, a painful and genuinely difficult to treat form of bone deterioration. Meanwhile, here's what the research consistently shows is one of the most effective ways to prevent fractures in older adults. And it isn't a pill at all. It's fall prevention. Balance training. Studies on Tai Chi specifically have shown meaningful reductions in fall risk. Removing tripping hazards at home, loose rugs, poor lighting, cluttered walkways, installing grab bars in bathrooms, getting vision checked regularly, reviewing medications that can cause dizziness or low blood pressure, making sure protein and vitamin D intake are adequate. These interventions carry essentially zero medical side effects, and the evidence behind them, particularly for balance training, is genuinely strong. To be completely clear, medication is absolutely appropriate for many people. Those who've already had a fragility fracture, or whose bone density scores are significantly low. This section is specifically about the situation where an active, healthy 74-year-old with no fracture history is placed on long-term medication almost automatically, without a broader conversation about alternatives or actual risk reduction numbers. A question worth asking your doctor: before we talk about medication, can we review my actual fall risk factors? And how much does this medication reduce my fracture risk compared to a structured balance and fall prevention program? This last one is the one almost nobody talks about. And based on the research, it may be one of the more consequential. A carotid artery ultrasound checks the large blood vessels in the neck that supply blood to the brain. The logic seems airtight. Find a significant blockage, clear it surgically, reduce stroke risk. Simple, right? The reality is more complicated, and for people with no symptoms, more concerning than it first appears. Here's the key fact. The surgical procedure used to treat a carotid blockage, called a carotid endarterectomy, carries roughly a 2 to 3% risk of causing a stroke during or shortly after the procedure itself. In older adults, particularly those with other health conditions, that risk can climb higher. The U.S. Preventive Services Task Force explicitly recommends against routine carotid artery screening in adults with no symptoms, no mini-strokes, also called TIAs, no episodes of vision loss, no other neurological symptoms. Their review of the evidence found that in people without symptoms, the risk of surgical harm tends to outweigh the potential benefit. Here's why that's the case. Many people over 70 have some degree of narrowing in their carotid arteries that has been present, stable, and silent for years, never causing a single problem. Routine screening finds it. A well-meaning specialist recommends fixing it. But the surgery to correct a blockage that was never causing symptoms can, in rare cases, dislodge a small piece of plaque that travels directly to the brain, potentially causing the very stroke the procedure was meant to prevent. I'm not going to walk through a single hypothetical case for this one, because the pattern shows up broadly enough across the research that it doesn't need a dramatized example. The consistent theme in the data is people entering a routine screening appointment in good health and leaving on a very different trajectory. Not because of the blockage that was found, but because of what followed it. If there are any symptoms, sudden vision changes, facial drooping, arm or leg weakness, sudden difficulty speaking, a sudden severe headache, please seek medical evaluation immediately. Everything in this section applies specifically to routine screening in people with no symptoms at all. Symptoms change everything, and time matters enormously with stroke care. A question worth asking your doctor: since I have no neurological symptoms, would managing my blood pressure, blood sugar, and other stroke risk factors be a more appropriate priority than a routine carotid ultrasound? High blood pressure, by the way, remains the single biggest modifiable driver of stroke risk, far more impactful, for most people, than anything a screening ultrasound alone can address. I promised you something practical, so here it is. Anytime a screening test is recommended, especially if you're over 70 and feeling well, bring these 5 questions with you. Write them down. Put them in your phone's notes app. Bring them to every appointment. Question 1. What is the false positive rate of this test for someone my age? This tells you how likely the test is to send you down a path of unnecessary follow-up procedures, even when nothing is actually wrong. Question 2. If this test finds something, what are the realistic treatment options for someone my age and health status? This shifts the conversation from, what did we find, to, what would we actually do about it? Which is the question that really matters. Question 3. What is the procedural risk of the treatment we'd likely pursue? This is the question most people never think to ask. Every procedure carries some risk. You deserve to know it up front, in plain numbers if possible. Question 4. What happens if we monitor this instead of treating it right away? For many conditions found in older adults, watchful waiting with regular monitoring is a legitimate, evidence-based option, not a lesser one. Question 5. What is the most effective non-invasive option for this condition? As we saw with bone health, heart health, and stroke prevention, lifestyle changes and medication often perform just as well or nearly as well as invasive procedures, with meaningfully less risk. Any good physician will welcome these questions, and most will respect you more for asking them. If a doctor ever dismisses these questions outright or makes you feel difficult for asking, that itself is useful information about whether that relationship is the right fit for you going forward. I want to close with this thought. There's a real difference between medicine that finds things and medicine that helps you live well. After 70, the goal of your healthcare shouldn't simply be to generate findings. It should be to protect and extend your quality of life, your independence, your energy, and your ability to keep doing what matters to you. You have every right to ask what a test is actually looking for. You have every right to ask what happens if something is found. And you have every right to ask whether a resulting treatment would genuinely improve your life, or simply change what's written on a chart. One more time, because it matters. This video is general, educational content based on published research and national guidelines. It's not personal medical advice, and it doesn't replace a conversation with your own doctor, who knows your full history. Please use everything here as a starting point for better questions, not as a final decision. If this video gave you a new way to think about your healthcare after 70, I'd genuinely appreciate a subscribe. I put out practical, evidence-based videos like this every week, and I'd love to hear from you in the comments. Has a routine test ever led you somewhere you didn't expect? Take care of yourselves. I'll see you in the next one.